Thank you so much. My name is Biraj. I'm a breast radiologist, and I'm so excited to be here with all of you today. Thank you for coming, and thank you for the kind invitation. So I'm going to be talking about artificial intelligence, my very favorite topic in radiology, and I hope soon to be your favorite topic also. Sadly, I don't have any disclosures. And I'm going to talk about a little introduction to AI. We'll talk about how it's being used currently, some steps that we all need to take in order to bring it into our clinical workflow, and then some ideas about the future of AI. So starting with the introduction, what is AI? What's artificial intelligence? It's really an umbrella term that says the ability of a machine to mimic human intelligence. Within that term is machine learning. We tend to use these kind of interchangeably, but they mean a few different things. Machine learning means that now the system can learn and improve from its experience. And then at the core of those is deep learning, which is more complex algorithms that mimic the way our brains work. So our brains are made up of neural networks where the neurons are all connected back and forth. And so if we see a cat, we immediately know that it's a cat. So machine learning scientists have tried to mimic this architecture using these very complicated, what we call neural networks or convolutional neural networks of different layers that communicate back and forth with each other to see what humans are kind of seeing. So I'll give you an example. So the classic example in breast imaging is telling apart a cancer from something else. So on the left, we have a speculated mass, and that's a cancer. And on the right, we have a benign mass, that's a hamartoma. So one very classic machine learning task is telling these two apart. We could also choose a different task, like telling chihuahuas and blueberry muffins apart, which apparently is harder than you would think. So a little history lesson. We started out with computer-assisted detection like 30, 40 years ago, and this was human designed. Basically, the computer scientists asked the radiologists, hey, how do you do it? And I would say, well, I look at density, the shape, the way the mass interacts with its the margin, and then the computer scientist would try to build an algorithm, like basically a little equation that it can apply to mammograms. And then using these rules, it would kind of, if you can see, there's like a little star here and this little triangle, it would kind of put markers on your mammogram. And to be honest, this didn't work. It didn't find more cancers, and it didn't decrease recall rate. So it doesn't work at all. So then we got a little more fancy, and we started doing machine learning. With machine learning, there's still a radiologist involved, saying, all right, let's look at shapes, let's look at margins. But the classifier, which is basically just a fancy statistical algorithm, got a lot more complicated. And this started doing a better job of telling apart blueberry muffins and chihuahuas. And then we got to deep learning. So now we took this radiologist out of the picture, and we didn't tell the algorithm what to look for. We just gave it a lot of data, hundreds of mammograms that were normal, hundreds of mammograms that were abnormal, and let it learn its own way. So it was building a representation of the data on its own without following human rules. So as an example, this is how it works for facial recognition. The first layer is just doing light and dark pixels. The second layer is starting to do some edges and some simple shapes. The third layer is looking at more complicated shapes like ovals, and then the fourth layer kind of starts defining a face. So this is doing it on its own without a human having to say, look at the eyes, look at the nose, look at this and that. So this is how neural networks kind of learn the way our brain works. So why are we hearing so much about machine learning all of a sudden in the last decade or two? Well, a lot of things have come together that have made it possible. First is we have faster internet, and we have a lot more data storage. So now we have these online databases, literally millions of images that we can all use to train our data tools. The computers have gotten better, right? Graphics processing is much faster. The algorithms that the computer scientists have built are online, so they're sharing with each other and allowing everyone to learn from other people's advances. And that's allowed us to make breakthroughs in designing these neural networks, which didn't exist, decades ago. So now that we have all these databases and these strong computers, basically our goal is to look at, find relationships in all of these images that are not available to human eyes or human brains. We have so much data to parse, and these powerful machines are looking at the relationships for us. So with all of this, I really hope that someday we'll be able to tell the difference between Shar-Peis and towels. All right, so that was a very quick introduction. So I'm going to tell you right now what we're doing using AI in breast imaging. So there's a lot of areas where we might choose to use AI, and the purple text boxes show where there's a potential of use. So a woman comes in for her screening mammogram. The first thing we might do is find lesions. And that's what I was starting to tell you about, looking for benign or looking for malignant lesions. Say she has a lesion and then has a biopsy. So AI can be used for histopathology and some of the genomics of the lesion. We can try to mimic oncotype or learn from oncotype and mimic prognosis and risk. We can try to predict treatment response, such as PCR. Say the woman doesn't have a breast cancer, but we're just reading her mammogram. We can use AI to look at breast density and then tell her how much of a risk she has of masking, where we won't be able to detect an underlying cancer due to dense breast. Maybe she should get a screening ultrasound. We're using AI to do a better job of cancer risk prediction. And then there's all these workflow advances that I'll get to. So first, talking about just lesion analysis. Mammography is the most advanced of our imaging tools because it's been around the longest and we've done the most research with it. And this is a really impressive study, one of the first big studies from the Netherlands, where they basically trained an AI to read mammos and then compared it to radiologists. So this is what their tool looks like. So hopefully you can see over here, there's a red circle. Yeah, I hope you can see that, around a little tiny mass. And on this side, there's a yellow circle. And it's giving a number between 1 and 100. And the higher number means more likely to be cancer. It also gives an overall number to that mammogram, 10 being the worst, being most likely to have a cancer, and 1 being the best. So when the radiologists read with this tool, their sensitivity went up from 83 to 86%, which was significant. And their specificity also went up in a non-significant but almost significant way from 77 to 79%. So this is amazing because it's actually very hard to improve on sensitivity and specificity. As you know, they often go against each other. Once you get a little more sensitive, you have lower specificity. So these AI tools are doing an amazing job decreasing our false positives and our false negatives. And then the other thing that was interesting is that the radiologists noted that when they had lower scoring mammograms, 1, 2, or 3, which the AI is telling them unlikely to have a cancer, they could read through those quicker. But then if there was a high scoring mammogram, 9 or 10, they were actually spending more time reading those. So this is sort of a workflow tool where it's helping the radiologist pay attention to the right things. Maybe I would want to read these more challenging mammograms after lunch instead of before lunch. This brings us to our collaborative work at NYU. It's led by Linda Moy, who's a radiologist, and Christoph Jaros, who's a machine learning scientist. And we trained on over 200,000 mammograms, which, since each mammogram has 4 images, is almost 1 million images. And then we pitted our AI versus 14 radiologists, including yours truly. And this is what we found. So our individual radiologist accuracy was only 77.8%. It's actually not bad. But the model did better. So an AI is outperforming an individual radiologist. But then when you look at all of the radiologists together, they're still doing better than the model, which means that some humans are still finding cancers that the model is not finding. And the best performance of all is when you combine the AI model with the radiologists. And that's really showing that radiologists and AI are still seeing different things. They're still each bringing something to the table. And these are some examples not from our study, but I just wanted to show you. This is a cancer circled in the yellow boxes that all radiologists missed in this particular study, but was detected by the AI. And then here's one that all the radiologists found. Seems kind of easy to find, but somehow the AI missed it. And that's because the AI is not seeing what we see. It has its own rules going on. And so together, we still work better with AI than by removing the radiologist entirely. So that was mammography. What about ultrasound? This is our NYU study where we trained the AI on almost 300,000 exams. And the AI had good accuracy of 0.96, better than the radiologists who were at 0.92. And so when we combined our powers, we found that our false positives decreased, our biopsy recommendations decreased, and the sensitivity stayed very high. So this was a great addition to our workflow. This is what it looks like when we use AI in ultrasound. On the left, here's a mass seen on 2 views. Looks kind of irregular, and all of the radiologists said it needed a biopsy. But the AI covered it in this green cloud, which means it thinks it's benign. On the right image, if it had thought it was malignant, it would have a whole bunch of red spots on it, but it didn't. So the AI correctly identified this as a benign mass. This is a fibroadenoma, while to human eyes, it looks suspicious. And then there's also AI for MRI. This is a University of Chicago paper. Basically, same theme. The AUC, or the accuracy, improves from 0.71 for radiologists alone to 0.76 when they use the AI. And that product, which is a commercially available product, looks like this. You click on whatever it is you want to analyze, the radiologist clicks, and then it draws a red border around it and then analyzes its shape and heterogeneity and other factors and compares it to other similar findings and then gives you a score as to how likely it is to be malignant. So all these products I just showed you are commercially available. Here's a list from 2022 of FDA-approved products. You'll see most of them are from the last 5 years, and there's even more this year. I don't want to go through all of them. I'd shown you this one already. There's another little ultrasound one. So there's a lot of products out there. The problem is that we don't have a very good standard for which ones we're starting to use. You might be from different institutions and see something different in every single place. So none of this is really standardized across the United States. Another place where commercial products are going strong is just density assessment. So, you know, we'll look at this and say this is a fatty mammogram, look at this and say she's dense. But the AI products give us a real quantification of the volume of the tissue and give us a number, which in the 3 means heterogeneously dense. And there's a lot of products doing this out there. And then one more type of product I want to talk about, which is workflow. Here, it'll, on your reading list, it'll tell you which mammograms are suspicious. So again, you might want to read those early in the day. You might want to have the resident look at them because these are good teaching cases. So this is sort of a triage workflow product. And then there's a bunch of products that come in even before the patient gets her imaging. For example, in decision support, there's products who are looking at trying to browse through the EMR and the clinical notes, and if they see something, they'll maybe suggest to the clinician, oh, maybe you'd want to order this study for your patient. And then once the study is ordered, how can we schedule the patients in a more clever way? There's also all these technical improvements, such as reducing radiation dose. This is happening right now for CAT scan, reducing scan time. At NYU, we've halved the scan time for knee MRI using AI. And then this one is not currently being used, but I think it's a really intriguing idea, which is maybe we don't need to give gadolinium, and there's enough information on the non-contrast MRI images that the AI can see for us. So we're not there yet. This is a sample paper on brain MR, but I think that's a really intriguing idea. So here's your CME question. Artificial intelligence tools may be used for the following purposes: workflow management, lesion detection, reducing radiation dose, and risk assessment, and all of the above. And hopefully I've convinced you that the answer is all of the above. All right, so moving on. Let's talk about what we need to do for AI to be become a bigger part of our lives. So a lot of these products have been vetted in very controlled environments in one little university setting with one group of patients. So we really need to see how they performed out in real-world conditions. So radiology as a group got together and said, we really need better standards for the data collection because it's all about good data. If you have garbage in, you're going to have garbage out. And we also need better standards for sharing our findings because we need to make sure that something that works at University of Chicago might also work at NYU. Another issue with AI is this black box problem. If you've heard of the black box, basically that means that now that we're not teaching the machine learning algorithm what to look at, we actually don't really know how it thinks, right? We don't know what it's seeing. So since we don't understand it, it makes it hard for us to trust it. So one way around it is to insist that it gives you this heat map, which I showed you earlier on the ultrasound. This is on a mammogram. You and I can see that there's an irregular mass on the left image. And if the AI marks this as a suspicious mammogram, I want to know what it's seeing. So thankfully, it's put this little red dot right on it, so I know it's finding the same spot suspicious that I'm finding suspicious. That's what I want to see. This one's kind of a good lesson. These folks wanted the AI to learn to find pneumonia. So it did a very good job predicting whether or not a patient had pneumonia. And then they turned on the heat map and they saw that the AI was looking over here in the left corner. And what it was looking at is this marker. So on every x-ray, we mark left. And so the one in the outpatient facility looked like this, and the one in the ICU looked like this. And this is actually what the AI was seeing. It had figured out, it had exploited this trick that a lot of the ICU patients had pneumonia and very few of the outpatients did. And so it had completely gotten this workaround and still had pretty good results. So thankfully, we had the saliency map to understand what happened, but this could be happening and we wouldn't know why the AI is having the conclusions that it has, and they might be completely erroneous. Another thing to think about is bias. So I said already, garbage in, garbage out, but also you can have very good data, but just on a small group of patients in a small area who are all the same age or the same ethnicity. And so your training set is very homogeneous. How is that AI algorithm going to perform in the real world when you have a different set of patients? We want to make sure we're not introducing bias or inequality in our algorithms. Another thing to think about is ethics. If the AI makes a mistake, who's going to be responsible? The person who developed the model or the radiologist who uses that model? And we all need to ask ourselves, what level of error are we willing to accept? There's always some degree of human error. Are we holding AI to a higher standard? Are we accepting a 0 level of error? These are difficult questions, and I don't have any answers, but it's something that as a community we need to think about. And it's sort of similar to what's going on in the self-driving car debate. For example, if there's a pedestrian on the road, should the car stay on course and harm the pedestrian, or should they swerve and possibly harm their own driver? These are some ethics questions in the whole entire AI space in general. All right, so here's another CME question. In order for AI tools to be successfully implemented, the AI tool will need to show generalizability across systems and patient populations, thought on legal ramifications, explainability, and consideration of ethics and equity, and all of the above. So hopefully I've convinced you the answer is all of the above. All right, and now let's get to the exciting part, which is what's going to be happening in the future. So there's a lot of different research going on now that is going to give us some better answers in the near future. For example, one thing that's really lacking in AI is comparison to prior studies. So when I read a mammogram, I'm always looking at the prior mammograms to look for change. Change is super important when it comes to breast imaging. But there's no AI algorithm that does that yet, just because there's so much data involved. So people are working on doing that. Integrating multiple modalities is another one. You know, when I read a mammogram, I also look at the MRI and the ultrasound and the whole picture, and we don't have algorithms doing that just yet. What about incorporating the EMR, the patient's chart, additional information from the patient? We need to start doing that. But now I'm going to tell you about two big future directions that I think we're going to see in the next 10 to 20 years. And one of them is triaging, where we're going to completely shift the work that radiologists do. So we have tomosynthesis exam, the AI is going to analyze it, and it's going to triage a certain percent of patients for review by the radiologist, say maybe 40%, and then the radiologist is going to read those and decide what to do. And then another subset of cases is going to be basically entirely dismissed by the AI if the score is low enough. So we are not here yet, not to scare you. There's obviously a lot of legal ramifications, forget about billing and reimbursement ramifications that have not been sorted out. But I think the research shows that this is very promising, actually. So I'll show you, this is a large Spanish study where they retrospectively went back and looked at 16,000 exams and then ran this model to kind of see what would have happened. And now in Spain, they have double reading, which is this top line here. So there's always 2 radiologists that read every mammogram, but we don't do that in the US. So we're going to be down here on this line, on the single human reading. So with these 16,000 images, a single radiologist would take 284 hours to read them. But if the AI got rid of the bottom 70% of cases that it said, no chance of there being a cancer, this is totally normal, you don't need to look at it, then the radiologist would only have to work 78 hours. But what about missing cancers? So the AI also was tasked to recall patients on its own if it found a very suspicious mammogram. And so it actually increased sensitivity. Now this was non-significant, but it certainly did not find fewer cancers. We did not miss any cancers by doing it this way. And the recall rate stayed about the same. So really interesting idea to decrease workload. This is a personal interest for me. But I think it's interesting just to think about like how we can use our workforce in the future. This is another one where they retrospectively kind of did the same exercise to see which percentage of mammograms they could get rid of. And they saw that if they got rid of 10, 20, 30, 40, up to 60% of the lowest scoring mammograms, they could just take them off the radiologist's plate entirely, and they wouldn't miss any cancers. Now, if you accept a little bit of error, you can dismiss even more mammograms, right? And this might be a discussion to say, all right, well, are we okay with missing 0.3% of cancers? Perhaps not, but it's something that the community will have to discuss. And then at NYU, we did the same simulation on ultrasound, and we found that if we dismissed 60% of ultrasounds, we would miss 1 out of about 12,000 cancers. Just a simulation. Again, we're not here yet, but it's a really interesting question, I think. All right, and then the last thing I want to talk about for future directions is risk assessment. So we have these powerful AIs for cancer detection, and there's something in the images, something about the complexity of the parenchyma that puts people at risk. And we don't see it, but maybe the AI does. So it would be interesting to use AI to predict future risk. So now I'm not talking about finding cancers anymore, right, but predicting future risk. And if we could do that, we could really better triage patients to whatever they need, supplemental screening, maybe even some prevention. So in terms of breast density, we know density is an independent risk factor. So women who are less dense, over here, have lower risk of breast cancer than women who are more dense, like this one over here. But that's not the whole story, because there's some women with fatty breasts who get cancer and plenty of women with dense breasts who never get cancer. There's more to the story than that. Ultrasound also gives us some information about composition. There's some ultrasound that shows a lot of involuted stromal tissue, involuted glands with stroma, and then there's some that shows a lot of glands. So what is this ultrasound parenchymal texture telling us? And then same with MRI, there's more biological information on MRI with background parenchymal enhancement. So this is just the general enhancement of normal tissue. Some normal tissue has no enhancement. In this patient, we're just seeing blood vessels. The breast itself is not enhancing. And then going from here to here to here, in this last patient, you can see the whole breast is basically white and enhancing. So there's something about her parenchyma that is picking up gadolinium, that has a lot of blood flow. What is different about her structure than the other people's structure? So there's a lot of information on our images that we can harness and, better predict people's risk. So this is a really interesting manuscript from MGH and MIT, and they basically developed a deep learning model to determine breast cancer risk over 5 years. So they went back to 5 years before, looked at all those mammograms, and then predicted risk. And they were able to put patients into low-risk groups and high-risk groups that were independent of their density, but were still 100% based on their mammogram. So there's something about this mammogram that somehow allowed the AI to put her in a high-risk bucket. Now, I don't know what it is, and I bet you guys don't know what it is, but there's something there. And then similarly, this dense patient somehow can be in a low-risk group that the AI is triaging. And then these percentages show that over 5 years, those people in those buckets really did develop breast cancer at different rates. What's interesting about this study is they also compared it to Tyrer-Cuzick. So we have Tyrer-Cuzick over here in the blue with the lowest accuracy at 0.61 in this particular population. And then this was their imaging deep learning model. And then if they added in some clinical features, that was the most accurate. If they used imaging and clinical features to predict risk, they did a pretty good job at 0.7. Now, then they split it up into ethnicity. So Tyrer-Cuzick didn't do so badly in the white group. In the white women, it was at 0.62. But in African American women, it honestly didn't do well at 0.45. And that's because Tyrer-Cuzick and other clinical risk models often have been developed and validated in white populations, so they don't perform as well in other populations. However, this particular deep learning imaging model had a larger group of patients, and so it ended up performing equally well in white women and in African American women. So this is what I mean about thinking about not introducing bias into our data sets and making sure that we're using data sets that allow us to be generalizable to the United States population or wherever we want to use them. All right, so I think this more accurate risk assessment is a really interesting future development, and we're going to start including more things, family history, maybe personal genetics, whatever we can find in the EMR. We need to take all this data together and integrate it together to be as accurate as we can. I think that in the end, this might allow us to de-escalate screening for some people. If we find a really truly low-risk population, maybe they don't need a mammogram every year. And on the other hand, we may be better able to identify the high-risk population who instead needs to escalate their screening regimen. So we're not here yet, but I think this is a super exciting possibility in the next 10, 20 years. All right, so I'm going to finish up with my take-home points. Number one, radiologists working with AI algorithms are more accurate than radiologists alone or AI alone. AI can be used in really every single step of imaging, starting with scheduling, processing, detecting lesions, and then down the line even with prognosis. AI is only as good as the data used to train it, right? So we have to stay aware of potential bias. And some big future themes, decreasing radiologist work and predicting future risk of breast cancer. And so with all of this, I really hope that eventually we'll be able to tell the difference between barn owls and apples. And I would love to thank my collaborators, Christoph Jarris, Linda Moy, and Laura Heacock, who've been amazing, and also thank all of you.